Welcome everyone to the Remote Patient Monitoring Innovation Challenge Showcase. My name is Ella Schwartz and I am with the California Healthcare Foundation, an independent philanthropy that is dedicated to improving access to care and quality of care for low-income and vulnerable communities in California. The team I'm on, the Health Innovation Fund, invests in emerging health technology companies that we believe can provide solutions to the pain points in the healthcare delivery system. And we work with health system partners on the ground, like providers and payers, to adopt and scale innovative technology. I think we can all appreciate how challenging this year has been for healthcare, but that also opens an opportunity for innovation like telehealth and remote patient monitoring. Our provider and payer colleagues are concerned about engaging patients in virtual care. And it's particularly important that we engage patients with chronic health conditions like hypertension and diabetes. And it's imperative that we support patients that are disproportionately impacted, like people of color. It seems like everyone is researching remote patient monitoring solutions right now. So we decided it's the right time to design this challenge and curate solutions. Before we dive in, I'd like to take a moment to thank the incredible team that designed this challenge. Over the past couple months, we worked with investor colleagues from Adaptation Health, Acumen America, and Health Equity Ventures to identify technology solutions that would be scalable and effective, especially in the safety net. We also engaged safety net providers and thought leaders from throughout California. Thank you to the incredible team from Northeast Valley Health Corporation, Petaluma Health Center, Shasta Community Health Center, and the Center for Care Innovations for your insight. Our design team identified 4 criteria that are integral to successful remote patient monitoring solutions. First, solutions should be culturally responsive. Second, technology should integrate with existing provider workflow and software like electronic health record. Third, companies should offer easy patient onboarding and engagement. And last in our criteria, the company should have experience working with safety net populations. So with all of that, we received almost 50 applications from innovative companies. And after a rigorous review, we are excited to introduce you to 6 companies today. We want you to be involved in today's event. Take a look inside the Zoom chat. You'll see a few resources. There's a welcome packet that gives you more details on each of the companies and presenters you'll meet today. There's also a short form in there if you want to connect with any of the companies that present directly. And we encourage you to ask questions throughout today's event. Please use the question and answer button in Zoom. Let us know who the question is for so we can direct it to them. And if we can't respond live, we'll follow up afterwards. We're also recording this so that you can access it afterwards. Now, before we meet the companies, we're going to kick things off with an expert provider panel. Please welcome to the Zoom stage a fantastic panel of safety net physicians. We've invited them here today to share how they are thinking about and using remote patient monitoring in their clinics. Welcome, providers.
Thank you.
Dr. Edgar Chavez, Chief Executive Officer and Founder at Universal Community Health Center. Welcome, Dr. Danielle Oren, Chief Medical Informatics Officer at Petaluma Health Center and Chief Medical Officer for the Redwood Community Health Coalition. And welcome, Dr. Christine Braid, the Medical Director of Virtual Care Services at Dignity Health. I'd like to invite each of you to give a quick background on your health center, the populations that you serve, and your experience with remote patient monitoring or telehealth. Start with you, Dr. Chavez.
Thank you for having me. It's a pleasure to be here. So as you said, I'm the CEO of Universal Community Health Center. We're a small community clinic in Los Angeles, fully funded FQHC. We service mainly the Latino underserved population of South LA, downtown Los Angeles. We have 3 clinics. We service about 7,000 unique patients, and we do 30+ visits a year. And we got into telehealth really early on when the pandemic kicked off in March. And we have been using the telehealth to kick off our efforts to get to remote patient monitoring.
Great. Dr. Oren?
Thanks and good morning. I work for Petaluma Health Center. We're a federally qualified community health center in Northern California. We serve Southern Sonoma County and West Marin, which include both suburban and rural areas. We serve about 35,000 patients. We have about 110 providers that span primary care, behavioral health, dental, vision, eye care, wellness, and a tiny bit of specialty care. We have 4 main sites, 2 school-based health centers, and 1 site at a homeless shelter. About half of our patients speak Spanish only. And to date, we've dabbled in a little bit of remote patient monitoring and a few efforts around blood pressure cuffs that connect with our patient portal, using iPhones for transition of care for complex patients, and diabetes blood sugar monitoring, continuous glucose monitoring systems, and attached monitors. Some of the barriers that our patients face have been connectivity, especially in the more rural areas of our community, affordability, availability of devices, tech and technical literacy, which we see both in the remote patient monitoring space and also in telehealth, and then language barriers depending on what device or tool that we're using. But I think that there are definitely ways to overcome these challenges if we're intentionally looking to address them like we are today. And I think that's one of the things I'm most excited about today's demos for, is the real focus on the safety net. I think that we may need to have many solutions to address all of our barriers, or one solution that works for most, and then an increased amount of people power to really address the most vulnerable population. So excited to be with you today. Thank you.
Thank you for that context, and we're glad that you're here as well. Dr. Braid, do you want to give a background?
Sure. I'm Christine Braid. I am Medical Director of Virtual Services for Dignity Health, and also work with Common Spirit for National. And I'm a family practice doc, and so I have a lot of experience in the ambulatory and also in acute space as well. Our population is a nonprofit, large medical group that's integrated in ambulatory space and also in hospitals throughout California. Just in the Sacramento region, which is where I practice, there are 75,000 underserved lives that we service for Sacramento area. In the remote patient space, we've been actually doing quite a bit of remote patient monitoring for the years, a lot with chronic care conditions and diabetes, hypertension, monitoring CHF, and integrating that into ambulatory space. For the acute, we do hospital home, ER transitions. And so we're looking at how can we balance that population across. So I'm really interested in all of how we can expand to our underserved population. Very excited. And I really appreciate being here today.
Great. Such an expert group of family physicians. Thank you. So our first question is for you, Dr. Oren. You actually served on the design team for this challenge, so thank you. And our question for you is, why is remote patient monitoring so relevant today? And why is cardiometabolic such a good place to start?
Thanks. I think I would start by saying our previous model prior to COVID and prior to the use of telehealth so prominently in primary care wasn't really that great in terms of monitoring people with chronic illnesses. And many of the same same barriers that face our patients in remote patient monitoring actually face them in in-person care as well. And there were some additional barriers: transportation, affordability of office visits, the fact that there may not be office visits available at every health center at every time. So I think we're really familiar with those barriers too. And I'm not sure that interacting with people 2 to 3 times a year who have uncontrolled chronic diseases like high blood pressure or diabetes is really the most effective care for those people. And I think there's a real opportunity here for us to do something different. Around cardiometabolic care specifically, there is some urgency around this because of the pandemic. We have many people who are avoiding in-person care. So we're going from intermittently monitoring them 2 to 3 times a year to basically none at all, which definitely puts people at risk for either going from a controlled chronic illness to uncontrolled or uncontrolled to having an event. And it definitely has the potential to worsen outcomes. And because these problems are really so prevalent, it really just lights a fire under all of us in terms of really needing to address this. I think it's also worth thinking about, and we all know from our personal experience that the stress of the pandemic has really affected people's lifestyles as well. And so we know that in addition to not being monitored, people might not be eating as healthy, they might not be exercising unless their pandemic activity was to start an exercise program. But I can say from my experience speaking with my own patients, that's not all that common. So I think, you know, again, that there definitely is some urgency around this. In a model with less in-person care, heart disease, high blood pressure, and diabetes are pretty much impossible to monitor if the patient doesn't have home equipment. And doesn't know how to use it. So as my own health center shifted into majority primary care being delivered in telehealth, one of the first things we noticed was how few people had a blood pressure monitor and how difficult it was, even if they did, to get these measurements and to get them into the EHR and have it integrate into our regular workflow and system of care. So we quickly realized that if we're going to deliver high quality of care virtually, we have to find ways to provide monitors, to provide education and guidance on how to use them, and how to get systems in place that would get the information back to the care team and into the electronic care health record. Sorry. I think that we do have, as I said at the beginning, we have an amazing opportunity here as we have transitioned to telehealth to increase the access to good care by providing information and guidance to patients where they are and when they need it, that can really overcome some of the barriers that we really faced in in-person care. I think we have the possibility of preventing more cardiovascular events by monitoring patients more closely, having more measurements, adjusting medications and care plans and goals as needed, rather than at these couple times when we happen to get to see the patient. And lastly, and maybe most importantly, we can really help patients engage with their own health information and increase their self-management of these chronic conditions.
That's great. Thank you so much for sharing that context, and totally appreciate, you know, given the geography of your health center and the diversity of your patient population, that this is a really exciting opportunity. So we're really grateful for those comments. In a follow-up, a question for Dr. Chavez, remote patient monitoring is going to generate new streams of data. Why is this information important for your practice, and how do you prepare to manage this influx of new data?
Thank you for that question. So as I said earlier, we springboarded telehealth to try to do remote patient monitoring because of the nature of how it's reimbursed. There is no real reimbursement for FQHCs because of the way that we get paid. And so there was a huge barrier for us to even get started. But once telehealth started and we started connecting with patients, we really quickly jumped on board to deploy a remote patient monitoring program. And we called it the analog remote patient monitoring program, where we essentially bought a whole bunch of these non-connected, very inexpensive blood pressure monitors. And so we started like the other presenter, we started with blood pressure, and we sent them out to people. And we gave them all these sheets where they would write the information, and then they would either drop it off at our clinic or they would take pictures and send them to us. But we very quickly found that this type of data gathering was not very efficient. We couldn't get it very easily into our electronic medical record, and it was hard to get people to actually do this. We had to call them, make sure that they wrote it down, and so there was a lot of barriers on this, what we call analog program. And so we started searching for a solution that would be a little bit more digital, where people would get connected at home with a device, and then the device will collect information and send it back to either a portal where we could easily just export that to our EMR or directly to the EMR. And so we started connecting with different places, and it's really difficult to find somebody that wants to work directly with your EMR. Everybody has a portal, everybody has a service, and the service is really expensive. And so for us, that was a huge barrier. And so luckily, because of what's happening with COVID, there's a lot of grants that came on board, and we started getting some funding to get some of these companies to work with us. And so we started a program with a company, and now it's fully deployed. And these devices are now digital. They're sending them to patients. In some cases, somebody mentioned that there's a lot of barriers with connections with internet, right? And so a lot of the times you want to give these connected devices to patients, but they don't have Wi-Fi, they don't have internet, they don't have anything that would connect that device and send the data. So you're back to being analog, right? So one of the solutions is some of these blood pressure devices have their own LTE so that they can collect the data. So this company allows us to sort of be flexible with what the patient has at home so that we're able to collect that information. And so now that we're starting to see the data coming electronically into our portal and then to a medical record, we have developed a team of providers that will look at that data, and the system alerts us when that data is at a range so that we're able to have meaningful actions for that patient. Hey, your blood pressure is going out of whack, let's bring you in. And so one of the things that we're trying to do to sustain the program in the future, because the funding's not going to be here forever, especially, hopefully they will change the rules for remote patient monitoring. But if they don't, one of the things that we hope to do is that doing this data sort of evaluation is going to generate some visits that are billable so that we can sustain the remote patient monitoring program.
That's great. Thank you so much for sharing the insight on tracking all of that data in your internal workflow. Dr. Braid, we're going to jump over to you. Can you tell us a bit about how remote patient monitoring fits into a larger health system like Common Spirit, and how do you use remote patient monitoring to support your best clinical practice and quality improvement?
Sure. I'd be happy to. Thank you. So when we think of a big system, one of the difficult things that we have is that continuum of care through and discussion with patients and physicians. So as we grow and as we combine, Common Spirit is actually two very large corporations coming together, and we don't have the same medical records, even close to the same medical record system. So how do we talk to each other? So virtual has been a really unique place where we can start to exchange information, kind of like we are here today. We're all together, though we're all in remote locations, so it's kind of cool. And one of the pieces that we're starting to use to really keep that continuum of care, particularly from a hospital space to a post-hospital space like home health, into the ambulatory space, is remote patient monitoring. So we're using RPM as a tool to watch the patient while they're in an acute space, keep set of the vitals, communicate with the physicians, then as they go into a home health, keep the same remote patient monitoring, hopefully, or at least the tool of remote patient monitoring, so that at home health, the nurses can continue to watch the patient. And then when we go back into the ambulatory space for the chronic care condition, to continue with the patient. And again, if that's something that we could implement while they're in the hospital, then we can arm them with the tools to keep at home. So we're not relying on them to have to come into my clinic to pick it up, or they're, if we can do it at the site of the hospital. Our hospitals here in Dignity in the California area are the sisters, the Mercy Sisters. We actually have a charitable need, and they actually are great into the giving and help our patients that cannot pay for the remote services. So that's something that we're looking to access. So again, this is something when you came, I was like, oh my gosh, this is amazing. This is right in the line of our philosophies and of our giving in our company. So I was very excited. And but when we're thinking of connecting the patient, and so one of the things I usually try to explain to my physicians is, there's only one patient. I said, so when we're going from hospital to my office, sometimes it gets disconnected. So my hospitalist is taking care of the patient, and then my home health takes care of the patient, but the patient's getting jumbled around. So if we can use virtual, particularly RPM, as something that keeps that patient feeling like they're always complete. So I, as the primary care physician, can always understand what's happening, and the patient is always in good communication with their provider. I think that's a goal. So that's where I feel like is the future of where we can go, and we're there. And we can really pull this huge corporation together and make it feel very family, very home, very connected, so that we're back to our little doctor's office, and that the patient feels like that they have a one-on-one relationship with their physician again, and not part of this massive corporation that they got lost in. So.
Great, thank you. That's an exciting model around continuity of care. We're so grateful to all three of you, early adopters and champions of remote patient monitoring and telehealth. Thank you for sharing your perspectives in this panel. And I know from experience that the three of you on this call are some of the most innovative providers and part of very innovative health systems in California. So thank you for being here with us. We would like to jump into the vendor presentations next. And I can see that people have already started using the question and answer feature in Zoom. So please keep doing that. Send us your questions. Let us know, which vendor it's for, and we'll make sure that they're able to respond. Each company is going to have about 12 minutes to present, and then there'll be a few minutes for question and answer, so we can hopefully get to some of your questions live. Our first company to present is Lucid Act Health. We're really excited to showcase them. They are committed to ensuring their technology is accessible for all patient populations. So welcome, Grace. Oh, you're on mute.
Hi, good morning, everybody. Can you hear me okay?
Yes.
So thank you so much. We're very excited to be here. This is a great opportunity to kind of share our journey with everybody. I'm Grace Chen, the CEO of Lucid Act Health. We are a San Francisco, California-based early stage company. We started doing remote patient monitoring about 18 months ago. So far, we have close to 3,000 patients, Medicare, 100% Medicare patients, about 70% of Medicaid patients on our remote patient monitoring platform. So today, I really want to kind of share with you our solution, as well as a lot of lessons learned and the journey we have taken. First of all, I really want to share, like, remote patient monitoring industry, like the physicians have just shared, is really at an inflection point. The experience we have had so far for the past, maybe 2 years is there's a mixed results. What we have learned is that a lot of the remote patient monitoring solution is very much device centric. There are so many medical devices with fancy interfaces out there. And there is a missing link between the patients and the providers. A lot of times the data are typically just trapped or stuck in the patient's phone. There is no direct link for the physicians to quickly take a look at the data and take actions if something goes wrong. And also, this is the current remote patient monitoring solutions where program is not really part of the provider's workflow. Just like Dr. Egger said, how to get those data into the existing EHR is a huge challenge. So Lucid Act came out, our remote patient monitoring from day one when we designed the solution. Our focus is to make the patient experience, patient onboarding extremely simple. Also for the provider side, want to make the provider's experience a lot simpler and make their ROI, how to they make the reimbursement from Medicare work for the providers, how to make the operation easier and not have to hire a lot of new people just to manage the program, and basically make the ROI works. The last piece is really, there are so many more devices coming to the market, and they're more innovative, much smaller size. How to introduce them to the providers in a much easier way than creating different remote patient monitoring process with different companies. And then also, patients want to have their own blood pressure devices. What are you going to do with that? So I would like to kind of quickly go over our solution from the patient's perspective. We have 5 different devices, from blood pressure and thermometer. They're all Bluetooth enabled. Very a special part of our hardware devices, we designed and deployed a gateway hub. This hub has a 4G LTE network enabled already, chip inside. It can automatically communicate with all the devices through Bluetooth and send the data to LucidAct Cloud through basically cellular network. The other part of this, that you can see the box, this is kind of our generation box. It's pretty bulky, but we purposely designed that way with big buttons. Sorry, with big emergency buttons that patients, it can serve as a PERS call center, PERS services. We provide 24/7 personal emergency response services. This box can also talk back to the patients after they take their blood pressure and say, hey, your blood pressure is this, and is activated. The language, we can customize this box to speak in multiple languages, from English, Spanish, Chinese, and Korean. So that's very much customizable. We recently get into a contract with a medical center who is serving the biggest Chinese population in Northern California. So this language customizable capability is very important for them. So that's kind of, Dr. Egger just mentioned a moment ago, like how can we transition from analog to a more digitized way. And then we put a lot of efforts in this. I first tested out this device with my mother, who is, Medi dual eligible patient, who is very much non-tech savvy, but she knows how to use a blood pressure, measuring my dad's blood pressure for years. So, and then when I got her approval, I know this is a good solution for many of the non-tech senior patients. And from there, our second kind of part of our service is we offer a remote call center staffed with certified nurses and pharmacists. So this is more of a distributed, remote team who can help kind of be the insert layer between the massive amount of vital data from patients' home to the provider side. There are a lot of, we send, at the very beginning, we send a lot of alerts, and we need a kind of a intermediate layer to filter the alerts and get symptom checked out before escalating to the physician side. So, so that's kind of the second part we are offering. The third piece is really the cloud-based care management platform that can, retrieve the data from our hub. Just like the doctor mentioned a moment ago, we got so much data, especially from EMR as well. We're part of the Commonwealth Health Alliance HIE. So we can merge the patient's health history, medication, diagnosis, allergies, and with the conversation that the nurses took, tons of data coming in. We have created a kind of AI algorithm just to indexing and categorize the patients based on the frequency of the vital data or alerts. as well as whether the data is out of range or not. So what we have done is we categorize those patients based on 16 different categories of their social determinants of health need. So this area, I have to say, we have started. There's still so much work to be done. Right now, we can create a very effective a patient outreach list for the nurses to outreach more effectively than just responding to out of range alerts. And this just passed during the summer, we created a conversational bot by providing resources. So if patients has issues with housing, COVID testing, food banks are in their neighborhood, in their local resources, we can have used the bot to respond to that. So far, we have created that database for California only. So at the moment, we are working with about 46 clinics, close to 3,000 patients. We have observed about 18 to 30% of our patients ended up triaging to the providers, potentially prevented unnecessary hospitalization. So I really want to share one of our patients' testimonial is that they said they have their blood pressure for years, but they want to only use Lucidax blood pressure cuff when they're not feeling well, because there is a nurse will be monitor the data and might call them afterwards. So you can see this is a lot of change management involved. Patients have their own devices. How would the new RPM solutions help them? So we really believe, the future is the home. There is hospital at home, primary care will be at home. Many of the healthcare services will be provided at home, though. So we all started with taking vitals from home. So we really believe this is a huge opportunity in front of us, and we really need to figure out how to make it work both financially and operationally. And technology is not the only solution. So this is our conversation. If this is our contact information, if you'd like to talk more with us and see a demo, start a trial, we would be very happy to talk with you. Thank you.
Thank you, Grace, for sharing Lucid's solution with us. Love that you tested it on your grandmother. There was a question in the Q&A about how you incorporate patient feedback in your design process. So if you want to follow up there, that was one great example of incorporating patient feedback. We have a couple of questions for you that we think might be helpful for the audience. Can you tell us a bit about how you think about the Medicaid market and how it might be different for you than your Medicare patient population that you've previously worked with? What are some of the opportunities that you see with engaging Medicaid populations?
Yeah, I think Medicaid market at the moment, there's no strict reimbursement financial incentive to launch this program. That's what we saw the initial hurdle to get remote patient monitoring launched quickly. On the other hand, by working with Medicare patients or programs, we really learned that this is a good way to have a touch at patient's home. And when I was working for Stanford, I really observed the biggest barrier, even for the oncologists and the doctors, is as soon as patients walked out of the office or out of the hospital, you really don't know what happened at patient's home. Besides the clinical vital information, there is mental health issues. There's like home supporting issues. There are a lot of things going on at patients' home, and especially for Medicaid patients, right? There's more than just clinical related information, things going on, more than just like medication adherence. Their family support, food, and housing are, on patients' top of their mind. So how can we get those information earlier and then know about it, and also connect them with the local resources? There are so much help out there, but people just don't know. So we really believe for Medicaid patients is when we talk about patient engagement, it's more like we need to bring value, bring actual result, help to them at home, and then they will be more engaged with any programs like this.
Got it. There's a couple questions in the Zoom around integration with provider workflow and clinical decision support. Can providers customize what their sort of boundaries for metrics are? And can you comment on your integration with electronic health record and the ability to pull data out of LucidAct and push it into the EHR?
Yeah, absolutely. So on LucidAct platform, we are the providers can customize two things. One is their workflow. We have a very unique, innovative workflow engine where people can just design their workflow, assign their own team members, and we will create a patient's task list and patient list for each user. So that's one thing. Second thing is providers or the nurses can also set customized thresholds for each index, whether it's blood pressure or heart rate or weight. They can set the threshold, and then the alert setting, whether it's increased by 3 pounds for CHF patients or 4 pounds. So we have that built in. It's very effective. That's how it drives our alert system much more effectively. I was thinking about the other one. Okay, so like how to get this data all back into the EHR system. So we have kind of multiple ways. One is we create a monthly or even weekly, that depends on the frequency. It's as a PDF, and we can ship it back to the EHR through APIs. And that's kind of the initial process we're doing. We are setting up a very big partnership with an EMR integration company who will be able to bring this data, like discrete data, back into, say, Epic's flow sheet, or like more into the actual data table into the EMR system. So that's kind of is underway. Hope I answered your question.
Yes, yeah, for sure. And there's a question in the chat that really resonates for me because we've seen a lot of providers kind of rush out to buy devices like cuffs and scales and pulse ox, but then not really sure necessarily how to implement. So if you have a provider that already has the device, can they pair it with your 4G gateway, or how can they connect into LucidAct if they already have the device?
Yes, absolutely. That's a really great question. And that's exactly why we built a hub. The hub is very dynamic. We can pair up with different kind of, as long as there are Bluetooth enabled devices. And then what we've really seen is this is the blood pressure cuff, thermometer, weight scale is like the first generation of remote patient monitoring devices. For 2021 Q1, we will introduce newer, more innovative, smaller sized devices, like the first portable nebulizer, or a patch, like a Band-Aid sized EKG devices. There are so much of innovation going on in the device market, but they all have to kind of create their own tunnel into the EHRs and workflows. So we come in, we want to be the hub, either a virtual hub or a physical hub, to connect all these different devices, give providers or patients a lot of choices to see which device, whether it's a monitoring tool or a treatment tool, they can adopt rather quickly and easily, reduce the friction. That's kind of our roadmap for next year.
Great. Thank you so much, Grace, for your thoughtful responses and your great presentation. There's a couple more questions in the Q&A for you to respond to. And for the audience, please keep the questions coming. We're moving to the next vendor, Remedy. And we are excited to introduce Remedy and their data-driven clinical management platform. I welcome Remedy to take the stage.
Great, thank you very much. Glad to be here, and let me share my screen. Wonderful. Well, good morning or afternoon, depending where you are calling in from. I'm Lucy Ide. I'm the founder of Remedy and now our Chief Health and Innovation Officer. So Remedy is a company based in Atlanta, Georgia, but have been working in California for quite a long time now with some great partners there. And our mission is really to help optimize clinical outcomes. RPM is a big part of what we do, but it is certainly not everything we do. So we have a deep history in sort of workflow optimization, clinical decision support, and patient engagement. And so I will present in this RPM focused context, try to address the breadth of what we do, and specifically in high risk and underserved populations. Our opinion of how we get to the healthcare system of the future is aligned with some of the points that were made by the panel and by Grace in her presentation of, moving towards this continuous model of care, fully utilizing data, both from the home as well as the electronic medical record. And we also do bring in patient-reported outcomes measures into that equation to really give a holistic view of the patient, especially focused on patients with chronic conditions. As a physician by background, I'm really aware of sort of the all-consuming nature of workflows in the electronic health record, and that this has to be part of that EHR-driven workflow and that data from the patient in the home, whether it's device data, wearable data, patient-reported outcomes data, has to all be brought into that existing workflow. So I sort of give an overview of our platform, there are really 4 key components to that. There's the integration into the workflow piece. So we were a very early adopter of Smart on FHIR, if you're familiar with that. FHIR being the widely adopted common API interface between EHRs and really all health data today in the government as well. So we've been at that for a long time. We were one of the first applications in Cerner and Epic as they moved into that. And today we're in Cerner, Epic, NextGen, Athena, and can really work with any of the EHRs that support FHIR. Clinical decision support, right? So CDS hooks, again, for people who are familiar with technology, is like the next sort of chapter in the story around FHIR and interoperability. And all that means is all of us in the industry agreeing on how we do clinical decision support and how we do that in the workflow in a really nimble and configurable and customizable way. So I'll show you more what I mean by that. Patient engagement and education. Again, helping keep this connectivity across the continuum with patients at home. Patient education is part of that. So we do offer digital education courses, sort of a Netflix on-demand version of traditional patient education that might have happened in a hospital or in the clinic. For those patients who just can't access that face-to-face education for various reasons. And then remote patient monitoring, as we're talking about today. And so we use these core pillars of our platform to support the use cases I'm showing in the middle. So we take a very sort of problem-oriented, disease-centric approach. And again, across diabetes, fatty liver disease, heart failure, cardiovascular, so hypertension falls into that, obesity, and then some COVID work, right? Like everybody else over the past 8 months. Got to click, there we go. And so, our goal is recognizing it's very hard for clinics and health systems to interact with a lot of different vendors to solve one particular problem, right? So trying to provide multiple benefits and sort of address all of the needs for any particular use case in one platform. And so again, solving that workflow integration piece with the EMR integration, helping plug in the patient engagement and education. So we do have two-way messaging built into the platform to be able to message back and forth with patients, as well as integrated patient-reported outcomes which we actually leverage text messaging to deliver those, but being able to bring those into the platform, write them back directly into the EMR, and as well as, sort of bridging the quality measure piece. So all of you, I'm sure, report out on quality measures, both internally, but then externally to your payers and to CMS, and helping really bridge that from sort of quality measures being one thing to report and clinical decision support being a different thing that happens at the point of care. We need to get alignment of those two, as that's really a single effort, right, with different endpoints to it. And then I'll talk a lot about the remote patient monitoring piece of this. So before I jump into sort of talking about how we do this, I thought it might be interesting to share some recent data we have on patient satisfaction with being part of a remote patient monitoring program. And not only their satisfaction with devices and ease of use, but also sort of how does it change their perspective on their relationship. So one of the questions we asked was, since starting this remote patient monitoring program, how do you feel about your healthcare provider? And, I think we all would assume and hope that this would be the outcome, but the majority of people say they feel more connected to their healthcare provider. When we've done this a couple of years ago, folks, had the perception that they were actually seeing their healthcare provider more in person, even though they weren't. And then another really important piece is, how difficult is your device to use, right? And I think we all know that that's been a barrier with some of the early devices. And so 78% of participants here saying that they felt the devices were very easy to use. So I'll share a bit more data at the end of the presentation, but just wanted to start out with that, that little bit. So as I mentioned, our approach is really this sort of problem-oriented, disease-specific view. And so I thought I'd share on screen here for maybe folks who aren't as familiar with how applications can run in the EHR workflow. So this is Cerner, Millennium EMR. And being a, what they call a smart on FHIR app allows us to sort of run within the experience here. So the gray and blue part of this is Cerner. The white background is actually our application running in Cerner. So you can be in your regular workflow in that patient context. If you click on Remedy, up comes our screen. We have all of the data shown here is coming from the EMR. We're calculating some risk scores and alerts and insights about that data, but there's no additional sign-on there, and all of the data sharing is sort of real-time behind the scenes. So as I walk through sort of helping you understand more of what our experience and patient journey is like, keep this in mind that within that EMR workflow, you're in a patient context and then in and out of the application as if it were part of that EMR. Same with Epic, and I mentioned the clinical decision support. Epic has really great sort of innate support for CVS within their workflow. And so we can actually prompt and surface alerts and insights directly within Epic without even being in our application. And the others are all moving in this direction as well. So, as I mentioned at the beginning, we work across really the whole spectrum of cardiometabolic diseases, and we have remote monitoring solutions for all of those. I'm going to choose diabetes as a patient journey and use case example to show you what we mean by this sort of this end-to-end solution. And so from a clinician point of view, we're really looking at the holistic view of what's happening with that patient's disease, in this case, diabetes. And so we're surfacing to the clinician and sort of mapping against guidelines where this patient stands at this moment in time in terms of the screenings and medications and vital signs and labs, and how are they doing against guidelines. A big part of this is the remote monitoring data. So in that same screen, we show also the remote monitoring data that's coming from the patient at home. I'm a huge fan of the cellular enabled devices. So we have cellular enabled blood pressure cuffs, glucometers, scales. We do support Bluetooth devices as well. And we support continuous glucose monitoring like Dexcom, and as well as connected insulin pens. So whatever that data is that the patient has, that those accounts are connected and the data is streaming into our system within that EMR workflow. We have a bunch of different ways to really try to help clinicians visualize the data in the way they're used to. Diabetes, I think, is very particular this way, that there's, a lot of people have different ways they like to see glucose data. But, that's only the beginning of the story, right? Of getting the data from the patient in the home in a really frictionless way. And again, I hugely recommend these cellular enabled devices when possible, because it gets you over the hurdle with Wi-Fi access, internet access, pairing frustrations. The beauty of the patient just being able to use their device and have the data go is really tremendous. And then, for any one patient in context, that rolls up to sort of your whole population of patients who are part of that RPM program. And a question was asked earlier about sort of how does my system, or my clinic have input on, what are the boundaries of normal and abnormal, and when do I want to be alerted, and how does that work? So we use these patient registries, which is really usually the home of the workflow for the care teams who are monitoring these patients. And we set up the alerting based on, boundaries for things like glucose, but also based on the rest of those clinical decision support prompts, meaning if this patient has a gap in care, has an opportunity to, be more adherent with guidelines or improve their outcome, we configure alerts for your health system with your, partnership and input. And then those alerts both show up on this patient registry and can be prioritized here, as well as in the individual patient context. Just to briefly mention, I think patient-reported outcomes, is sort of been this parallel thing to remote patient monitoring, and to us, they're really part of the same story, right? Having the patient have their voice as to what's going on with them, whether it's a standardized PRO like a depression screen, or whether it's something custom and unique to your health system. We can generate these programmatically. You can send them on demand, but it sends a text message to the patient. They do it on any internet-enabled device, and the data comes back into our program, but also gets written back into the EMR as well. And so as we sort of walk through this journey, right, of having a patient who's connected at home, the data is coming in, it's getting merged with their clinical data, and driving insights about what can I do, what's the next best step in care, what are the gaps in care for this patient. This is an example of one of our clinical decision support prompts in a patient context. In this case, focused on, say, a medication gap in care. If your system was interested in, we're really not adhering to guidelines in terms of sort of medications around diabetes, we can build a pathway for that. That allows you to prompt your clinicians and allows you to capture what action they take about that. And then sort of, the last part, sort of the beginning and the end of this journey, right, is how well managed are these chronic diseases across your population. So we do a lot of work with clients to baseline that at the beginning, to target the particular patients. I saw a question in the Q&A earlier about, you can't monitor all of the patients, so who do you decide to monitor? And that is part of our process, is working with sites to help figure out what those criteria are and onboard those patients. But then to continuously report out, right? How are we tracking? Are we moving the needle on those key performance indicators? And then, as part of RPM, and I'm sure a lot of folks have been familiar with this, the tracking of the activity. And while it's been challenging for reimbursement for FQHCs, and we've spent a lot of time lobbying on that topic over the past year, we'll get there, I believe, in terms of reimbursement for FQHCs for RPM. And, then you have to be able to track the activity and report out on it for billing purposes. So this is built into the platform, sort of timekeeping and the ability to document the specific activity that was taken for that patient, and then to report out on that across your whole clinic. So many of our sites, will run these reports at the end of the month, and it aggregates the time per patient, per activity for billing purposes. So trying to really make that quite streamlined. The education, I don't want to not come back to this, just to give you a feel, diabetes self-management education has been really stagnant in the number of patients who've had access to that. I think, 4% of Medicaid patients on average, and only about 7% of all patients get access to DSMES. And so a couple of years ago, we built these sort of on-demand video-based courses. These have exclusively to date been deployed in hard-to-reach communities, some clinics that serve homeless patients and clinics that serve mostly uninsured patients. And we have some really great engagement and outcomes numbers there. And so we've done the same for weight management and fatty liver disease. Again, an area that's hard to get, have the time in clinic to spend educating patients and get that needed education to them. So I'll kind of close by wrapping back to these patient outcomes measures and patient satisfaction of, I think this is a hugely important one of self-efficacy. How do you feel about your ability to manage your healthcare condition? And 70% of patients saying they feel better about that. This is across diabetes, hypertension, and heart failure. I think another question folks have is, what's the relationship of the remote monitoring to in-clinic? Is it replacing it? Is it supplementing it? And so we wanted to get patients' perspectives on that. And the majority of them think that it does supplement face-to-face appointments, but some think it replaces it and may not have to have so many appointments face-to-face with their clinicians. So I see a bunch of questions have popped up in the Q&A, so I can try to get to those now.
That's right. Thank you, Dr. Ide. That was a great presentation. Lots of good questions in here. I know you mentioned, connectedness with CERN or EHR. Are there other EHRs you're connected with? And is there anything else about FHIR that you can share?
Sure, yeah. So we are in the marketplace for Cerner, Epic, Athena, NextGen. That means that we have sort of worked with them, done all of the integration work and been certified by them. There's another question, I think, about how long does it take to get deployed and onboarded. In those cases, right, we've done the 90+% of the work. So it's a really quite fast process for onboarding clients. More and more EHRs are currently supporting FHIR, right? It's been pretty much mandated by the government. And so for us to deploy in a new EHR that supports FHIR APIs is a really quick process.
Got it. And there were a couple questions around health equity and cultural responsiveness, language access. Could you we have just a couple minutes, could you share your approach to that?
Sure. So to date, we have worked primarily with English and Spanish speaking patients. Again, the patient-facing parts of our technology are, these individuals have devices at home. We heavily utilize text messaging, or, our end users do, to communicate with patients. Some of that is automated and we can program that in any language that we need to. And some of it is the clinician actually sending those messages, and clearly they could send messages in any language that they chose to. The sort of cultural appropriateness, health literacy was a big component of the education programs that we launched, because we were being intentional about what audience we were trying to serve there. And so we actually did several rounds of input from the community. We worked with a community in South Atlanta near our airport that's sort of traditionally hard to reach, underserved, 14-year life expectancy gap versus other parts of Atlanta, and had a board of advisors from that community who gave input on the course. I want to see more people who I can relate to, who look like me, and that was a really great process for us to improve that. I'll put in a quick plug, because I think this is a great audience for it, that there's a coalition that I'm co-chairing that's putting out a report at CES, the Consumer Electronics Show in January. But the Consumer Technology Association and Connected Health Initiative are working on a working group for health equity access and sort of guidance to the administration, but also to other companies, of how to build more equitable health technologies. So
that's exciting. We love that. Thank you for sharing your solution with us, and for all your thoughtful answers and time on the presentation. There's a few more questions in the chat for you from people who clearly know the safety net very well and are drilling down to exactly the right questions that we need to understand to be able to implement. So thank you, Dr. Ide. Next up, we'd like to welcome Blake from CareSignal to share CareSignal's exciting approach to remote patient monitoring, which is deviceless and instead focuses on automating communication and clinical intervention. So welcome, Blake.
Thank you so much, Ella. It's just a privilege to be here. I mean, everybody on this call is heroically working to support the people who need it most in this country at the perfect time. So I feel really fortunate to be here with you all. Thank you so much. I'm going to share what we're doing at CareSignal. We are, as you will see, we're fanatical about accessibility and scalability in order to drive clinical impact and then financial sustainability. I'm pretty humbled to share. Actually, this is the first time we've shared this publicly. This year, CareSignal will touch more than 1% of U.S. adults across the U.S., largely safety net populations. We have tens of thousands of active individuals at FQHCs, Medicaid plans, and a number of other large payer and provider groups across the country every single day. So before I dive into what CareSignal is doing, let's talk about the why, which is specifically, I think, we hear RPM, and usually we think about investing in the high risk part of a population, the top of my metaphorical iceberg here, right? And that's good, but in order to really bend the cost curve sustainably, and in order to scale the clinical capabilities that are already in place with your teams, we also need to look at the rising risk population. And a few different recent publications have defined this really effectively, and have also shown that that's the path to cost-effective and sustainable remote patient monitoring engagement in the long term. And exactly as Ella said, and I think, Dr. Chavez and Dr. Braid prefaced this as well, there's kind of this dance that we're doing, right? On the left of this Venn diagram, you have traditional RPM, which is great, but expensive and sometimes can lead to more tech support and implementation issues. And on the right is patient engagement. CareSignal is deviceless remote patient monitoring. Think of us as very roughly 100 times more scalable than a device or connected device approach at 10% the cost, but with all of the same clinical actionability. And what that winds up leading to is the ability to penetrate deeper in a population than would otherwise be possible. In terms of the how, well, I mean, we have a running joke that nobody can escape CareSignal. We use the technological common denominator. Text messages, phone calls, we can go through a concerned caregiver if a patient isn't comfortable asking or responding to questions. Now, here's the other part. A lot of our populations that we're discussing here today don't have unlimited text message plans, even if they do have cell phones, and just about everybody does. So CareSignal has formed relationships with all the big cell carriers, so we can push messages through for free and receive them back for free, even when a phone runs out of minutes. And of course, meeting people where they are means more than just technology. It means language, it means cultural sensitivity, and we support English, Spanish through to Bosnian is the most obscure language I can find that we have active right now. Now, just to hammer this home, right, accessibility really is king. We want to make sure that from a health literacy and even just a true literacy perspective, we're meeting folks where they are. Tech perspective, cost should never be an issue. And then we need to drive long-term engagement using that familiar technology. Now, there's another challenge that I really want to discuss, which is, a point solution for a given condition, even the most worthwhile conditions right now, diabetes, heart failure, hypertension, is just that, as a point solution. We take a portfolio approach. So in the upper left here, you see exactly what we're discussing, right? The big three, the common offenders, and then of course COPD, asthma. You can imagine that the pulmonology side is pretty adjacent to cardiometabolic. But CareSignal also supports behavioral health, social determinants of health. In fact, we now have more than 11 modules across the SDOH spectrum, maternal health, including breastfeeding adherence, such as for new mothers on Medicaid, and then a variety of complementary and supplementary programs, each of which is evidence-based. And when we started the company, we recognized that technology isn't really, the hardest part. The hardest part is capturing sufficient clinical and financial evidence that we can help often slow-moving industry to see that there is a way to, with positive ROI, to adopt new tech. And that's led us to conduct more than 5,000 patients worth of IRB randomized controlled trials and quality improvement studies. We've now published 10 peer-reviewed articles in different medical journals showing these reductions on the screen. And just a fun one to highlight, even though it's a little bit out of scope for this conversation, our COPD randomized controlled trial was one of the first, if not the first, placebo-controlled trials in digital health, where we even controlled for the Hawthorne effect to make sure that the impact that our technology was having was really its impact and not just, an observation effect. which could be then compounded by a regression to the mean issue. All right, so we're gonna take a quick beat here, walk through the CareSignal workflow. I'll share some of the partners with whom I'm privileged to be working across the country, and then time permitting, I'll talk about our team and a couple of quick case studies. When you think about the CareSignal workflow, it all starts with a list of eligible patients. We work with our partners to figure out not just the high risk folks, but the rising risk. And once we have that list of eligible individuals, that's provided to CareSignal. And again, we can do this standalone, but certainly prefer EHR integration. We really love our partnership with Redox for FHIR and just about everyone else. Then our team reaches out of engagement specialists, reaches out white label, and enrolls those patients. And this team is 11 part-time people right now. They'll make 6,000 to 12,000 calls to patients and members across the country this week. And we're reaching out to educate these patients or members on this new free program that their provider, even a specific care team provider, has for them to keep their heart healthy, to keep their blood sugar in check, to keep their mood well managed. The patients then enroll and begin interacting with our automated technology. Remember, accessible, scalable, automated. That's where the text messages and phone calls come in, even for populations that have pay-as-you-go phones. And as those responses are provided by the patients, the patient-reported outcomes, blood sugars, breathing day over day, mood, pedal edema, nocturnal dyspnea, all at a 4th grade reading level, then CareSignal can do one of two things. One, if we're integrated with the EHR, we can inform the existing workflows of those care coordination or care management teams, and that can be escalated to providers as necessary. Two, for groups that maybe don't have the operational and clinical infrastructure that they would need, we can use our own virtual care navigation team to supplement that care management, especially as that group is stood up within our partner. It's an analogy here that the tech folks will chuckle at, but this is kind of like having cloud flexibility before you bring something on-prem. And sometimes it winds up being more cost effective to keep it in the cloud for the long term. So, we're doing this with a variety of organization types. The common denominator across all of these groups is really the type of patient or member population. It's generally a rising to high risk population, lots of safety net representation. And there are some logos that I can't put on here, but some really large payers and payer provider joint ventures, as well as some really large Medicaid plans, including in the south of the United States. And these groups are all pursuing the same thing. How do you keep tough patients engaged as it relates to their chronic conditions for the long term? Which brings me to perhaps my favorite part before I go into a quick team and case studies. CareSignal has phenomenal engagement. I mean, we're really good at activating folks because we have that human touch up front. But after that, our half-life for this challenging population, just without anything else, is about 1 year. About 50% of folks stay engaged for a full year. But we're doing even better than that. So we have CareSignal AI, and I don't have time to go into too much depth, but CareSignal AI is able to predict which patients will disengage from our own technology with striking accuracy, 90 and 92% accuracy. And then our engagement specialist team can reach out and prevent about 57% of patients from disengaging that would have otherwise. And the kicker here, I think this is kind of evidence that preventative care really does work, is it's actually more cost effective for CareSignal to do that preventative re-engagement than it is to enroll new patients from scratch. So it benefits the patient, of course. It benefits our partner because they have better engagement with the existing population and can scale more confidently. And it benefits CareSignal too from a unit economics perspective. So CareSignal AI has been a boon. Now, something that I think Adaptation Health is rightfully focused on is the importance of equity and diversity. I'm really pleased that CareSignal is more than 50% minority and female as a team. We conduct yearly reviews to make sure from a salary and equity compensation perspective that there is gender parity, which is a passion of mine, frankly. And I'm really pleased to work with my founding team as CareSignal scales. All right, so now we're going to shift into a few quick case studies to give you a sense of exactly how flexible we are at scaling deviceless remote patient monitoring to different population types. I'll actually start here with the largest federally qualified health center in Colorado. In Colorado, we're privileged to work with Stride, a very large behavioral health provider, and other organizations supporting all safety net populations. This is kind of a prototypical use case. It starts with just one or two conditions, diabetes and hypertension, scales from there. CareSignal does all of the outreach and enrollment, and the existing care management team is able to scale their reach, billing for codes when possible, but driving quality, shooting for quality metrics that make this financially sustainable even while RPM isn't reimbursable. It shows in the data, and this is actually just the risk stratification data. But if we go up here to a large physician group based in St. Louis that was focused exclusively on CHF, diabetes, and COPD populations, not only were we able to ramp up to thousands of active patients in a matter of weeks, but CareSignal was then able to help this team scale from about 100 patients per care manager to about 1,500. The numbers don't lie. This team's own analysis showed a more than 10% reduction in total paid medical claims versus patients who were not on CareSignal. Even when you take into account the cost of the first event that made a patient eligible for CareSignal that could otherwise be a regression to the mean issue. And again, 46% reduction in CHF ED visits, 31% for COPD. I was really proud of these. I'll pause here to highlight yet another case study. We can kind of do this all day on the research and case study side, but that's right at time. I would love to answer any questions that anybody has.
Thanks, Blake. Great presentation. Lots of questions coming in. Would love to start with this one that came in from Susan, which is also very insightful for how the safety net experiences patient communication. Can you tell us, how do you manage getting the most current contact information for patients? This is a big struggle for us in the safety net.
Absolutely, and to some extent, that's one of the biggest challenges, right? Is making sure that the phone number stays up to date. We can do a couple of clever things, so we can validate and vet those phone numbers and figure out whether it's for a cell phone or a landline phone, which gives you a surprising edge when you're trying to figure out how to reach a patient. Empirically, I'll share something really interesting. Because CareSignal can still interact with phones once they've run out of minutes, we've seen from when we started our very first research projects many years ago that patients will sometimes have two phones. They'll have the phone that somehow keeps sending them messages about their health that they know matters, and then they'll have the social phone, which unfortunately turns over, so that number is a little bit more fleeting. But that's a phenomenal question, Susan. I'd love to dive in deeper with you on that offline.
Thanks, Blake. There's a very particular question in here about like texting regulation, and we definitely find that regulation can be an impediment to innovation, and every state might have some different regulation on how to communicate with Medicaid patients. Can you say a bit about how CareSignal thinks about staying in compliance with various states' regulations on texting, and how do you work with providers to understand that?
Yep. So there's kind of table stakes, which is making sure that you're compliant with the payer, especially Medicaid, and with the plan and their contract. Beyond that, though, it really boils down to consent. HIPAA specifically, you get it, Ella, you get it. HIPAA affords patients the ability to communicate how they want to communicate. That's written in. In fact, it's a violation to not communicate the way patients want. Try it. Email someone. Say you want everything from your EHR emailed to you. They'll do it, even though email is unencrypted. So in short, that's how we do it. But glad to dive in on HIPAA, TCPA, and then of course the backend SOC 2, Type 2, high trust, and everything else that you need.
Awesome. I've never seen anybody get so excited about HIPAA before. I know you mentioned about having, different languages. Can you say a bit more about how that works? Is it up to the provider to configure it? How is it that you have multiple language capacity, and how in-depth is that languages?
Great question. So these are the different conditions, or at least most of the different conditions that CareSignal supports. Because we have gone through the rigorous research and development process of developing content, the logic, and the algorithms that schedule the interactions, we have total control. Think of each of these as almost a molecule in a therapeutic, in a pharmaceutical, right? You don't just toss a new hydroxyl group on, right? The same way you don't just mess with. We've really honed this to make sure it's engaging, clinically impactful, which means that it's pretty easy to predictably translate it to new languages. So in the event that we encounter a population where we don't yet have that language, which is increasingly rare, then we have a third party that can translate it in about a week.
So it's more than just like straight translation. It's actually reflects the way people speak in that language.
Absolutely, and that's with one of our Medicaid plan partners. That was really an interesting. We actually have a separate version because there is a specific kind of idiomatic niche that they have with their Spanish-speaking population, and we had to make sure that we were accessible to meet those patients where they were, and not just force them into the box.
Got it. There's a very smart question in here about how you integrate with appointment scheduling software so that the provider isn't outreaching to a patient and there isn't actually an appointment available. Is that a part of your integration?
That's separate from CareSignal. So we'll inform just like RPM, right? Deviceless RPM. Our goal is to capture that actionable real-time data and make it actionable for the care team that's in place. And we have some recommended partners that can help with appointment scheduling and adherence, but that's adjacent too.
Great. There's a question in here about risk, and do you do any risk assessment or kind of categorizing patients by risk, and how do you approach
Yes.
that?
Okay, so risk. Here's the thing. Clinical risk is just half the battle. You also have to look at financial risk. And I think for federally qualified health centers, for those partners, that's intuitive, right? You're all ahead of the curve and feeling that. But when we're looking at implementing with a 5,000, 10,000, 25,000 patient population for our partners across the country, it's not just a discussion around what's the A1C, what are the ICDs, how many times was this patient in the ED or admitted last year, which is a necessary part of the risk analysis. It's also what are the contracts and how much risk is endured for each of those patients, so you can make sure to prioritize the right folks. So I could talk for a long time on that, but part of the consultative implementation is making sure that we're aligned financially and that we're going to be able to drive financial returns, not just clinical returns, once we go live.
Got it. And Matthew's question about risk is also reminding us of the importance of equity. And there has been, different news articles lately about there being an implicit bias and other biases that impact risk stratification and automation of clinical decision support. So how do you think about, health equity in the work that you're doing?
Oh my goodness. That's a thoughtful question. I think it has to come back to our product design. Our VP of product, Christine, has a background in healthcare communication research. And one of the reasons I think we were able to convince her to join our founding team is, we really do run studies through to full randomized controlled trials for each condition that we intend to tackle. And part of that is not cherry picking tech enabled or a certain racial makeup. It's making sure that you're doing research with a representative population and that the clinical outcomes are substantial across that population. So there's no silver bullet. You have to put in the time, do the research, go through the iterative design.
Great, thank you. Well, thank you so much, Blake, for your time answering questions and your great presentation. It's wonderful to learn about CareSignal. And there's a few more questions for you on Zoom, if you could check there to respond in detail.
You got it. Thank you so much, Ella. Thanks, everybody.
Thank you. Great, good questions, everybody. We are excited to introduce Ben from CertainTel Telehealth. And we are excited about CertainTel. They are providing care management and coaching services, often with Medicare populations and now expanding to include Medicaid. So welcome, Ben.
Thank you very much. Great to be here and super excited for the opportunity. And, one of the things, just a little background around CertainTel, we, exclusively focus on federally qualified health centers. We have worked with some rural health clinics, as well. And, really our goal is help as a social impact focus is really help closing the care gap. That's our core mission statement, what we've been doing for a long time. We've been fortunate enough to have some early opportunities with FQHCs around remote patient monitoring. We've learned a lot. We'll touch on that. We also work with now multiple health center control networks as a lot of their shift and focus, and folks that don't know what a health center control network is, they're there to help support federally qualified health centers and implementing electronic health records, optimizing that. And there's really been a shift because of COVID-19, focusing quite a bit on telehealth and connected devices. We've been fortunate enough to be partnered to support with some FCC grant funding to support those types of programs around remote patient monitoring, which is what we call telehealth 2.0. But one of the things that we learned a lot is the technology is great. It's important. Everyone has kind of touched on the key hot buttons of it's got to be accessible to patients, which typically means not having to have Wi-Fi in the home, be out of the box, able to use. And I would guess that almost everyone on here has that core, and we'll touch on that a little bit. But one of the challenges that we saw by working with implementations, even with smaller grant-funded projects around remote patient monitoring, is a shortage of staff. Certainly with COVID, a lot of organizations had to furlough staff. Folks are overburdened, just spread thin as far as from a clinical team to engage. So the technology is important, but do organizations have the support to scale? And the big part, of course, is monitoring the alerts, reaching out to the patients when there's an issue, reaching out to the patients when they're not taking the readings. But more than that, when you have that touch point, to be able to have trained staff, they're going to have an impact on behavior change when they get that touch point. And so as an organization, we're excited to touch on our platform in a bit, but what we do in support, just really understanding the challenges that FQHCs have of the number of FTEs available to really scale a program like remote patient monitoring. We want to help and be an integrated partner to really take that barrier away. And we do that with what we call our certified clinical health coaches. We'll touch on that in a minute, and how they're integrated with your clinical staff to really support a scalable remote patient monitoring program. And through our experience in clinical workflows, how from the patient perspective, they don't really know that we're not actually employees of the clinic, but they just know, hey, I have a health coach from this FQHC that's supporting me in my overall health journey. And so, what is a behavioral health coach? This is important. They're really behavior change specialists. We've taken a lot of time and effort through one of our key partners. We're out of Des Moines, Iowa, called the Iowa Chronic Care Consortium, or clinicalhealthcoach.org. It's a nonprofit organization. So all of our clinical staff that are trained on our remote patient monitoring portal and equipment also go through 40 hours of training around to be behavior change specialists, all in an integrated way with our FQHC partners. And so we help identify patient health goals and barriers, help create an actionable care plan of action, and really provide a patient-centered resource in between those in-person office visits. So as the end goal is really improving patient engagement and self-management. And so what's critically important about what we do too, we have significant training on socially determinants of health, understanding the challenges with the FQHC population, whether it's Medicare, Medicaid, dual eligibles, uninsured, who are engaging to really have an effective impact and understand those challenges that they have. And so get to the platform in a minute, the technology piece of it. But again, what we created a unique model that allows us, as folks have talked about, there are current barriers for FQHCs and rural health clinics that bill for some of these new Medicare remote patient monitoring codes that are exciting. But even again, if you could, the challenge is going to be having the staff in place, the highly trained staff, to really engage patients around a remote patient monitoring program. And so we integrate that with our clinical staff and lead as an extension, as a partnership with your organization as a health center. And so again, we start with our processes from an enrollment, which is important. There was a question around how do you identify risk and all of that. We have a NCQA certified health risk assessment. We have integrated that we go through with every patient before we would enroll them in remote patient monitoring. It's great because it helps in a really clear and understandable way, spits out a physician summary and a patient summary to really help evaluate which patients would be best served enrolled in remote patient monitoring. We have one specific to Medicare and one specific to Medicaid patient populations as well. And after, in a collaborative approach with our FQHC partners, we evaluate who's best fit, and then we do turnkey supply all the devices into the patient's home based off their health risk results. And so when you look at what we do to support FQHCs, again, you all do a wonderful job of providing comprehensive care, dental, behavioral health, medical, preventive service, all of that. What we're here to do is take some of that burden of limited time to spend from a time-based perspective in your high-risk patients. And so our health coaches reach out to the patients, contact them, consent them, enroll them in the program, and again, educate them on the devices. And I'll reiterate what a lot of other great companies have said and will continue to say is that, all of our devices we connect, our cellular connectivity. We'll talk about a unique partnership, a unique hub that we're super excited about to bring in multiple devices that the patient may already have that are Bluetooth enabled. But in partnership with our FQHC clinical staff, because they're your patients, again, we collaborate on target ranges, when should patients get alert, but again, we triage that to take some of the burden off of the staff internally. And again, folks talked about some of the sustainable opportunities with Medicare and dual eligibles as well. Sometimes we forget that with a lot of dual eligibles on Medicare, Medicaid, that they're eligible for these new remote patient monitoring codes that are out there. What's unique about our model is that we are a virtual medical practice that's credentialed with the payers. So in partnership, we can actually drive the billable codes, they're time-based codes, so we can collaborate together to make it sustainable that's not just dependent on grant funding situations. And so again, all of this you all know about, monitoring. It's all about the patient outcomes-driven approach. We're early in the stage in this new model, but again, we have some strong partnerships with 6 health center control networks to scale this. We're really going strong in states of Louisiana, Mississippi, South Carolina, for example. Utah is another health center control network that we're rolling this out and having really early success in partnership, getting patients that at risk devices they need, and in partnership driving that engagement in a coordinated care team approach. So again, everything as what we do is we're culturally competent. We understand the challenges that your patients have, because this is all who we focus on. And so again, we're there to provide in a collaborative way, rapport with patients, emergency protocols, and really streamline patient enrollment without having the FQHC have the burden of doing that all in-house. We're just here to help. And again, what a lot of the platforms have already talked about, we're no different. We're able to set parameters and alerts based off, when the patient should take their readings. That's a big one, right? A lot of times we focus on when the patient is out of range, which is important, but based off the clinical workflows and protocol of our FQHC partner, whether it should take the readings daily, every other day, the patient will get, of course, from accessibility, a text message. And what's also unique about our platform is phone alerts as well. So once the patient's in the system, certainly they can get SMS reminders. There's a comment or about, well, even some patients struggle with text messaging or access. We can also set them up in the system to get phone reminders. So it'll be an automated phone call to take their readings, and of course, if they're out of range, to alert not only the patient, but of course, our clinical health coach, as well as the FQHC care team, to collaboratively engage the patient. And so again, patient communication, we're there for technical support and provide patient education and resources through our clinical workflow. And then again, just really take some of the burden off with the team that this is all we do. Clinical oversight, we have a medical director, nurse practitioners, but our core of who does the yeoman's work are our certified clinical health coaches that are typically CMAs, LPNs, RNs, again, highly trained to be behavior change specialists. And so our process is about being trust with partners, doing it in a sustainable way, because we're able to actually bill the Medicare codes is a non-FQHC entity that's credentialed with payers, particularly focusing on Medicare, and we've gotten credentialed with many Medicaid plans as well. We know we're not quite there yet for RPM around Medicaid, but we are going to get there, particularly with the success around COVID of the Medicare RPM program. We hope that starts to trickle down to Medicaid. But again, a lot of our patient population we engage are dual eligible, so they have Medicare coverage, eligible for the Medicare codes, but also, of course, have Medicaid because they're underserved and low income. And these are the patients that are at the highest risk, multiple chronic conditions. Many of them tend to be older, having the higher risk of mortality around COVID. They're scared to come into the clinic or can't get into the clinic. And again, our goal in partnership is to do that. And we're starting to track outcomes today around patient engagement, all the core things around the quadruple aim that are important to FQHCs. So a quick and, just a quick view of a portal. We're absolutely excited about going in a more deeper dive in the demo of the platform. I'll show you a little bit of some readings, but a couple key points that the thoughtfulness of how this was built is that, we wanted to be patient focused. I think earlier on there was a comment around that. Couldn't agree more. It's about being patient focused. And so as you can see, our alerts, our reminders, the patients don't have to have a tablet or send them a smartphone. Again, we know some have challenges around, don't have a smartphone, of course, but perhaps you get access via SMS or have a phone. Those are how the reminders happen. But not only that, the patient can also allow through the patient access, send reminders and alerts to their family members, loved ones that are also engaged with the patient, because it takes a community to really make an impact around many of these patients that are having health inequities and challenges on that. So sometimes just having their sister or brother or mom or son that also gets alerts reach out, hey mom, you haven't taken your readings, what's going on, to have an impact. And our system allows that type of engagement and functionality. And just a quick view of, the platform, similar to what some of the other organizations have talked about, to be able to log in as a clinician and view alerts. Yellow, we're above the limit, green is, is good. And to be able to then drill into the different dashboards for the patient as well, and be able to view over time the different graphs and logs from systolic to diastolic, either in a graph or log area. The same with weight, glucose, and blood pressure as well. One of the things that I always want to do, some people may want to just see, well, how if you take a reading, how does that look to the patient? I'm actually very quickly going to take a quick reading. I have a blood pressure cuff on now, and just show kind of what the patient views from an SMS, text message, alert, or via phone when they're out of range. And while I do that, again, touch on some of the key functionality around that go beyond just the remote patient monitoring. Because remember, our health coaches in partnership, certified clinical health coaches are engaging with the internal FQHC staff. We can also do med alerts. So as we know, the med's able to pull med lists, be able to integrate that into our system, and also do the same with med reminders as well. And of course, it's all in partnership with our FQHC internal clinical team to set targets. And we can do different surveys and alerts, and of course, have some analytics dashboard of how the patient's viewing over time. We can track, of course, the engagement time to bill for the Medicare codes, but also what's the ROI from a cost of the staff, how much time they're spending. As it was touched on, you got to look at the clinical ROI as well. But we're super excited to, in the future, go on a little deeper dive within the platform and look at that and keep, show you what we're doing with other health center control networks and their FQHC members.
Thanks, Ben. That was great. We don't usually get to see the actual product, so it was fun to see a light demo. Thank you for sharing that, and thanks for your presentation. Getting a couple questions here for you, similar to other questions we've seen asked in the past. Do you have any ability to connect with other devices? Do you always supply it? Can you work with clinics that bring their own device?
Absolutely. So we can connect with bring your own device, similar to some of the other comments about accessibility. The devices that, again, we learned, over these implementations, cellular connectivity. So all that we have, a couple keys we can look at. So we have some devices we're very successful with glucometers and blood pressure cuffs and scales that have a cellular chip built into them that goes real time to the readings. We're excited about a partnership that we have with a company that actually has a really cool hub that allows to connect with multiple Bluetooth. So certainly when you're looking at Pulse Ox, which has been a popular device around COVID, but as long as the device has Bluetooth, it can connect to multiple devices to be able to do that. And the hub connects to all the cellular carriers to allow accessibility as well. And so, but certainly none of our devices require the patient to have Wi-Fi in the home.
That's great. I know you mentioned that you have like coaches within CertainTel. How do you work with providers that want to leverage their own local staff to do coaching?
Yeah, we've done that quite a bit, particularly with some of these FCC grant-funded projects that many of the FQHCs have received to implement connected devices. And so in that setting, we would, we license the platform. And so they can integrate and use that with their own internal staff. But that's kind of part of just what we've seen is even in smaller pilots, when I say smaller, we're talking typically less than 100 patients that they're budgeting to enroll. Still around alerts, we just find a lot of staff gets overwhelmed with the alerts and able to respond to them and all of that. And with all the pressures, when it comes to that fourth leg of the quadruple aim of care team and provider satisfaction, we just can't stress that we're here to help. We understand your patients. We don't do anything in a vacuum to do that. But yes, we've done multiple grant-funded implementations where they use our platform and engage with their own internal care managers and case managers and the like.
Got it. And speaking of integration, can you share which electronic health records you've worked with and whether or not you are FHIR compatible?
We are FHIR compatible. We've worked with, Athena. I think, there have been some great discussions, really great talk on the FHIR, with Remedy and awesome stuff they're doing. Next Gen is making things accessible. I always want to be upfront. We have very simple, easy to use APIs that wouldn't take long to integrate into their clinical workflows. As you all know, sometimes it's dependent on the, whether the EMR vendor wants to partner with you. One of the ones we're excited about that we're working towards a project is ECW, eClinicalWorks. We know that's a huge player in the FQHC space, certainly in California. We have, the APIs we have integrated with Epic, and we're kind of working through the health center control networks that have a lot of leverage with ECW to allow us to integrate our workflows. The integration is the easy part. It's just allowing them access. And the big piece of it is, which we've done with others, is where you want that data real time to feed within their clinical workflows dashboard. But we have a full clinical team and tasked to work around that project to do that. So, but we have with Athena, Next Gen, we're implementing one in Arizona, and ECW, we're excited to. We haven't done it yet, but we're getting close to implementation integration with them.
That's great. And time for one last question, which now I'm forgetting what I was going to ask you.
Okay.
Can you, right. So you mentioned the cultural responsiveness of your tool, and you have experience onboarding and engaging patients within your own clinical team. What have you learned about how to onboard and engage patients, and especially, ones that are diverse?
Yeah, it's really the resources that are sent out are critical. So one is just the pamphlets that are in English and Spanish, and really that's where we've shined is our clinical health coaches are experienced in helping patients enroll in our portal is real easy. You put in the CID code of the device and it's connected, out of the box. But so just being calm, helping the patients, particularly if we're dealing with older, to be patient with them and make them feel comfortable that they can do this. Self-management is important. So, but from a language, Spanish and English, but we do have integrated with we have a video telehealth platform as well, where we can on demand through audio or video bring in multiple languages to help support that communication protocol, engagement as well. But that's the core. We keep it simple. We do, again, we focus from a bilingual health coaches, our Spanish and English resources in Spanish and culturally understood clinical health coaches that are patients with patients when we help them make sure that they're comfortable with the technology.
Great. Thank you so much, Ben, for responding to all our
Sure.
questions and your presentation today. We're moving on to our next, second to last, but not second to least, vendor Alertive. And we're excited to show you guys Alertive and introduce you to Dr. Isola. Alertive is compatible with multiple devices and can be used at home or with patients that require a higher level of care, like a nursing facility or hospital at home model. So take it away, Dr. Isola. You're on mute.
Okay, hear me now? All right. I'm Dr. Rama Isola, Head of Business Development for Alertive Healthcare. You can see my screen. We started Alertive to prevent heart attacks and strokes, focusing initially on hypertension. We are founded by physicians, Dr. Nirav Shah, Dr. Jorge Sanchez, myself, and we saw the need for the continuous real-time care. We focused primarily, we started on the Medicare population and dual eligibility. We've also been working with a lot of the commercial population. And our goal is to really tie remote patient monitoring, these physiologic measures with medication management and titration to meds to improve health outcomes. There's our team, Dr. Nirav Shah, Dr. Jorge Sanchez, Noah Manders is our Chief Technology Officer. Mike Ju makes sure all our sales operations run smooth and implementations go well. I'm based in Los Angeles. Most of the team is based in Seattle. And Shock Jackson is our account manager. We'll be overseeing all our Southwest clinics and partners. Daniela Ruiz looks over our successful implementations. So we are a full platform for turnkey remote patient monitoring. When I say turnkey, I mean we will fully support from enrollment of the patient, to the monitoring of the patient, to the patient interaction, the documentation, care coordination, escalation of patients we're concerned about, all the way through to the billing and support of reimbursements for RPM services. We have Apple, our mobile app is available on Apple and Android. We also have cellular devices for patients without smartphones, and all this data goes live into our dashboard. We support blood pressure, weight, pulse ox, blood sugar, temperature, and we're also moving towards more acute monitoring with ECG and activity tracking. Giving you a high-level overview here, and I'll be sharing a video in a moment. We also have telehealth in our platform, and that gives a lot of value to the mobile app if the patient is able to have access to a smart device. We also could provide the patient with a tablet if they do not have access to smart device. Again, we get around that with the cellular devices as well. So we're really looking to improve the outcomes on the sicker population, the patients who need who are at higher risk. We would be great to work with. We would work adjacent to a team like CareSignal, which focuses on the general population. We deploy RPM for the higher acuity patients. We are full turnkey, meaning that we'll have the onboard of the patients. We can remotely enroll the patients or educate the staff to enroll them themselves. It's very easy. We can also proactively reach out to a population of qualified patients. We have a team that will reach out, educate, and reach out behalf of the clinic with their branding. We can enroll the patient remotely as well. We have an in-house care team, which is overseen by Dr. Jorge Sanchez, where we have our templates and care communication. We do all the documentation. A care team member is assigned, or multiple members will be assigned to a group to build that rapport with the patients. And so the patients will have that relationship and a continuous interaction with the same individuals. We also have practice managers on our team to ensure the billing is smooth and the reimbursements, hopefully through Medicaid, will be maximized as we find that the return on investment for an RPM program, there is the financial driver for physicians to really get on board and to bring patients into the platform. Let's share a brief video with you all.
Good morning. My name is Nirav Shah, founder of Alerted. And what you're looking at is a sensible remote monitoring dashboard. When you log in, what you would see is a risk stratification perception management across a variety of physiologic parameters that is customized. When we dig in, we can see that there's a patient in crisis that we want to evaluate first, Jorge patient. He's an individual with a systolic blood pressure of 191 at hospital. When we look at his patient profile, immediately what we see is real-time data of the systolic blood pressure. We can zoom in over the past few days to see how it's been doing. We can see that it's rapidly rising. As a brief tour, we can place calls, chat with the individual, and then also audit along to see who on our team has interacted with this patient. We can quickly scan and see their medications that are abstracted from the EHR and reconciled in real time. We can also look at blood pressure data as well as chart notes for remote monitoring and telehealth visits. In addition to this, we track consent for not only real-time care, but also clinical research, and can understand which devices and reimbursements he has accessible to him. Now, when we dig in deeper, it seems like we need to do a telehealth visit for this patient because of his acute change at home in his blood pressure physiology. And so from the dashboard, we can initiate real-time telehealth visits. Here's one where we send him a new device so that we can get him more advanced remote monitoring.
Hello, Dr. Thomas. Thank you for reaching out to me. How was my experience? It was great. Yesterday I got the BioHub and the Bio sticker all in one package, all in FedEx labeled boxes and envelopes to ship back when I'm done with it. Here is the Bio sticker, very light. It's got the sticker right there. Your team walked me through the process in 5 minutes. I was up and running in 5 minutes.
That's great. So now, from our dashboard, we're able to log in and remotely enroll patients like Jorge on his phone. As you can see in the co-browsing, remote enrollment data.
What we're showing here is that our technical team, the patient has a mobile app, can view the patient's what they see on their phone to help them navigate and enroll them into the program. The app will have multiple devices that they could pair with. We work with multiple vendors. They can keep track and see their histories of their physiologic measures. We also support manual entry. So if the patient only has one device, or let's say it's economically only feasible to deploy one device, they may have a weight scale at home. They could use a manual entry for that entry.
Let's say we check in a few days later because we're worried that Jorge has reported cough in his mobile app or via secure text back to our care team. Look at his physiologic parameters. There's some cause for concern as his respiratory rate is rising when he's approaching tachypnea. So ECG parameters and make sure that he doesn't have arrhythmia that's causing these new symptoms. We can zoom in and make sure that he's got good, healthy P waves and that there's no irregularity or cause for concern. Let's do another quick televideo visit and check in on Jorge.
I've been having some shortness of breath that's new. Yeah, only when I get up and I exert myself or walk out. I don't feel it when I'm sitting at work. I do have a cough. No, it's not productive. There's no phlegm, it's just dry. I've been having a feeling of being washed out. Am I wearing a patch? Yes, here it is. It's comfortable. I hardly know it's there. Good, you're gonna reach out for me in a couple of days? Good, I'll be looking out for your video call. Thank you, have a great day.
And that's a quick view of how we could do telehealth visits tied to his physiology based on real-time data. And then lastly, maybe we want to make a medication adjustment and look at his meds because we all worry that he's getting tachypnea, rather high heart rates, and maybe we want to change his dose in some form or fashion, and maybe perhaps even add another tablet later in the day. And we're able to do that also here in the dashboard and track this as well. Thank you for listening. My name is FHIR, founder.
Andy, a couple of other things I wanted to show on our platform is we have the risk stratification. We also have the alerts for the critical readings. Say a patient with CHF gains a few pounds, over 3 pounds over 2 days, will be notified. Our care team will reach out to it and communicate with the clinic as per their protocol. This is what the platform looks like for the medication data, all the documentation. All the documentation is tied to time. Also, since our care team has been using this for a while, as well as our partners, we've developed work lists to see, hold teams accountable, see what needs to be done or completed for next patient as you're managing a population. We provide full billing support and practice managers on our team as well. And with that, I'll leave some time for questions.
Great, thanks, Dr. Isola. A couple questions coming through the chat and some of the classics that we've seen before. Can you say a bit about how you integrate with electronic health record or FHIR?
Yes, we have REST APIs and we support Smart on FHIR. We've also, with a large academic center, they chose to move forward with a HL7 JSON via an FTP transfer of data. And we did that as we built out a whole COVID monitoring platform for them as well. And we're going into Athena Marketplace and numerous other EHR marketplaces.
Got it. And on the
one more, this is all stands. Our technical team, our IT team is all in-house, so we'll be building that out in-house.
Great.
So because integration may have different levels, of integration of what the client may want. So we're able to manage that in-house as we build that out.
Got it. And how about the clinical decision support or the parameters for what is considered, something that needs to be escalated or triaged by the provider? How does Alertive approach that, and can it be customized by the provider?
It'd be through the communication protocol. So I did show that we have critical alerts and the staging of hypertension. Those are based on guidelines, the medical guidelines are out there. But let's say a provider said, hey, I want to be notified whenever my patients are spiking above or blood pressure goes above 160 or of a certain parameter for glucose. Our care team would be educated upon that and communicate with that protocol. They may want to be, each client will be different. So they may want to be email and they may want their MA to get a text. So we'll customize that to their communication protocol. And
can that communication protocol also be pushed into the electronic health record and be an alert for the provider there?
Yes, we'll have EHR access and we could document it in there. And if some of our clients say, hey, message me over ECW for patients we're concerned about. So yes.
Got it. And that's in like close to real time.
Yes, we're looking at this. Some groups they may have said that they're like, we're not looking at this 24/7. I'll be honest. We have a care team that is looking at this 9 to 7. We're looking at chronic conditions, looking to manage the trends of the patient. But when we do see alerts or the patient is at a critical reading, we'll look at that first thing in the morning and reach out right away.
Got it. And I know you mentioned at the beginning how you work with Apple Health and the need for a smart device. And can you just circle back to that and say again, does the patient need to have a smartphone, and how does that work?
So they do not have a smart device. We have cellular devices, cellular blood pressure cuffs and so forth that they could just take a reading, automatically goes to the cloud. If they do have a smart device, there's a lot of value in the mobile app as it has notifications. They can see their histories, they can see their medications, they can request a medication change to say if another provider, say a primary care doctor adjusted meds and a cardiologist would want to know about it. They're also going to have the ability to video communicate. We have the capability for patients who do not have any smart device, we could deploy a tablet to them. So they would, with that tablet, along with that device, they have the access to telehealth and to the other values of having a smart device. So we have that capability.
Got it. That makes sense. It enhances the communication pathway. And did you talk about languages?
So yes, we do. We are 70% of my care team is Spanish speaking. We have our app available in English and Spanish. The mobile app is available there. Enrollment and all our tech support are all Spanish speaking as well. We can bring on other languages if there's a significant population.
Got it, great. And how do you think about cultural responsiveness and health equity in the work that you're doing?
Cultural responsiveness, I'm born and raised in Los Angeles. I've been living here as well. Most of our care team is on Arizona and LA area. As far as the Latino population, so Dr. Sanchez, he's been working in the rural areas of Arizona, Florida for quite some time. It's quite sensitive to that. We look to be diverse in the team members that we're bringing on as to be a better representation of the populations that we serve. We a very diverse group of individuals.
That's great. Good to hear. Great. Well, thank you so much, Dr. Isola, for your time responding to our questions and your presentation. It was great to meet you and get to know Alertive a little bit. Thank you. And we will move on to our final company, Memora Health. And we're excited to introduce you to Memora, which offers multiple patient communication modalities. And Manav should be here to introduce the company. Take it away.
Awesome. Can you all see and hear me?
Yes.
Okay, awesome. Well, I will hopefully finish this off strong. Thanks everyone for joining today. My name is Manav. I'm one of the founders and the CEO of Memora. We're a healthcare technology company that is a little over 4 years old now and based in San Francisco. And really at our core, what we do is we kind of focus on 3 areas: messaging, monitoring, and management, right? Making sure that we can guide a patient through an entire plan or care journey that they're going through. Second, monitor them along the way, whether that's device or deviceless. And then third is properly integrate that into the current workflow that systems may have so that all that information can be managed. We to date have worked with a little over 50 healthcare systems across the country, have worked in the context of federally qualified health centers. We've worked with IPAs, we've worked with really large academics, really large community systems. So kind of across the spectrum. And more than anything, what that has resulted in for us is very just deep understanding of how population or how different types of populations engage with technologies like this. And the most fundamental learning from that has been that, it's extremely difficult to deploy a lot of these different types of technologies, whether it's remote monitoring, whether it's patient engagement, whether it's, appointment related management, PRO collection, whatever it is, kind of as an isolated system or a system that says, look, we are solely responsible for this singular dashboard, for this singular, connected device that we want to implement, right? One, it makes it extremely challenging for clinicians to be able to adopt. And then second, it doesn't necessarily provide all of the right context for how a patient is actually performing. So we've taken kind of a different approach from most companies when it comes to remote monitoring, where we've actually started with qualitative engagement and then use that to identify where remote monitoring is needed. And that kind of brings me to the core problem that Memora solves, which is, fundamentally that patient communication and the processes that healthcare organizations traditionally use to aggregate information on how patients are doing is highly fragmented, right? So some of that information may come in from phone calls and end up in notes that are not, referenced ever again. Some of it may exist in an access center compared to existing on the clinical side, right? Some of it is in symptom trackers and FAQ sheets. And as a result, on the patient side, there's 8 to 10 different channels that they're often looking at and getting access to information from, and it's difficult for them to understand what is my core source of truth that I should be relying on. And then second, in parallel to that, it's extremely difficult for a provider to have a comprehensive view of this is exactly the journey that my patient went through, all of the information that they received, what they actually retained, and what data they actually tried to report back to me, right, in a very actionable way, right, instead of the scattered process that exists. And apologies, I think the biggest takeaway as a result of that is remote monitoring, particularly during COVID, has obviously started to take off, right? And there's this twofold reasoning behind it. One, that there's just such a critical need for us to meet patients where they are and to establish a stronger presence in the home so that we can remotely identify how patients are performing and identify who's at risk. And then second, in parallel to that, the reality is that remote monitoring is a great vehicle in the status quo to drive more revenue per clinician, right? By taking all of these processes that people may be doing right now in some fragmented way and centralizing it, documenting it, and making sure that it is in a reimbursable format, right? But the challenge of that is everyone has kind of jumped on the bandwagon of remote monitoring, and it's resulted in, a lot of sites actually having different dashboards for different devices that they're implementing, or one dashboard for deviceless monitoring, one dashboard for device-based monitoring, and things like that. And then no qualitative component kind of looped into that. A lot of that is quantitative data that goes in one place, but there's no relation between that and messages that a patient sends in on a portal or something like that. And as a result, only 35% of remote monitoring interventions across the industry are effective on average. And that's just based on, feedback that we've actually gotten from health systems that we work with, right? And then second, in parallel to that, is that in most people, remote monitoring is not necessarily effective if you're getting the reimbursement just because you're dumping so much data in front of the clinicians that they have to spend, the 20-minute mark reviewing it, or they have to spend a significant amount of time reviewing it. It doesn't necessarily mean that it's actually improving the standard of care. And I think that that's true for a large majority of interventions, in the sense that the average remote monitoring intervention in the industry increases the number of notifications that a clinician receives in any given day by almost 3x, right? And part of that is indicative of the fact that patients are trying to get the attention of clinicians more. And second is that, these interventions have been implemented in highly fragmented ways. So really the kind of longer term vision that Memora, has had health systems buy into is that there's all these fragmented systems that people currently use to communicate with patients, right? There's EHRs, there's CRM tools on the access side, there's phone call based follow-up and discharge calls that are made, there's email based outreach, there's portals and things like that. And while all of these to some degree will in some part of communication, it remains so fragmented that it's impossible to understand how a patient is comprehensively performing. And the second reality as a part of that is that at the end of the day, this process that every system goes through of trying to cram care delivery interventions into the medical record is increasingly accruing what, we on the tech side would call technical debt, in the sense that clinicians are becoming increasingly frustrated with how their EMRs are performing. And, that process has only gotten worse and worse over time. Second is that at the end of the day, it is still, there's not a single system that you can really point to and say, that system has helped me revolutionize how I deliver care for a patient. And it has fundamentally changed my day-to-day process, right? And that, hasn't come by in almost 15 years since EHRs became highly adopted. So Memora at its core is an orchestration platform that does a couple things, right? And I mentioned we have kind of reversed the model of most sites, where when we start working with an organization, the goal is to take all of these different communication channels that currently exist and say, maybe your appointment related messages exist in your CRM, maybe your clinical outreach exists in your EHR, maybe, you have some phone calls that your nurses are making as well and have to manually document right now and spend, $20 per note they have to document on average in the industry. Memora is going to come into an organization and actually build integrations into these tools to pull that data and out of those systems and orchestrate it into one platform. And the first goal of doing that, quite literally, even before we get to remote monitoring, is to say, here's the most comprehensive view you have of the entire journey your patient is going through, right? From this is when they got their first reminder, this is the phone call that they received before their appointment, this is the PRO survey that they're receiving from this one department right now, and here is the, additional message that they may have sent in from the portal, right? And as a result of that, we're basically saying this is almost infrastructure that is necessary to allow remote monitoring to properly scale, right? And that kind of brings about 4 buckets. If we're able to orchestrate all of that data properly and say communication at its core is the biggest driver of how a healthcare organization is able to communicate with their patients, retain them, make sure that the quality of care is high and stuff like that. We'll kind of clump that into 4 buckets of care pathways, PRO collection, patient access, and then remote monitoring is one of those 4 pillars, right? And as a result of that, the goal of implementing Memora at any organization is to say all these different buckets of content that you may want to deliver. So every single intervention that you see on the slide is something that every single system wishes they had, and they probably have a large fraction of these in different solutions. The goal is to say Memora is the platform that will aggregate all of that into a singular place and give you all of the qualitative context needed to make remote monitoring function properly, right? Which kind of brings me to the next point, where at our core, we've developed a comprehensive way of engaging patients. We can do it in 109 different languages. We can do it through 4 core channels of SMS, email, IVR, and WhatsApp. We can adjust frequency based on how patients are responding and intelligently understand their behavior in interacting with this kind of system to drive engagement and stuff like that. And basically put them on this journey or this plan of step by step, these are all the reminders and instructions that we are going to deliver to them. And then based on how they respond to that, we'll figure out who is potentially at risk. Which kind of brings me to the next point of, after we've implemented a lot of that communication infrastructure and taken this communication first approach, we actually will work with sites to identify, does this patient seem most suited for deviceless remote monitoring or device-based monitoring, right? And on the deviceless side, that means things like patient-reported outcome surveys. It means things like asking patients to just text in a copy of, let's say, a blood sugar measurement that they may be taking or something like that, right? It could be something entirely different from that, right? Where you're just asking them a survey, right? And then the device-based side, we have a spectrum of integrations that we have built with smart devices across Apple-based devices, Fitbits, accelerometers, SpO2 machines, CPAP machines, CGM devices, weight scales, things like that. And what we'll functionally do is say, we'll identify populations that are actually eligible for remote monitoring interventions based on, just indications and based on information that we've qualitatively collected from them, and then leverage a lot of that information. And after we've administered the device to them, we'll procure the devices for the site. We'll actually go through the process of getting them to the patients and put them through an entire text-based education program that guides them through how to set up the device and what the purpose of that device is, which has been a critical step for driving engagement. And then after they're using it, use that device data to actually inform what types of messages we are sending to them, right? So we, at the end of the day, view engagement as the core driver of how this intervention would perform, right? And we'll send them, what you're seeing is an example of like a PDF, which gives them an overview of what their entire care journey is. We'll send them text-based messages. We'll send them alerts saying, hey, you need to make sure you schedule transportation to your visit. And if you haven't, you need to reschedule a visit at this phone number, different things like that. Collect a lot of that device-based data and conduct something called event-based triggering, where let's say that we're collecting CGM data, right? Use that to send out intelligent surveys asking a patient, hey, we saw that this metric was, your blood sugar was 120 at the fasting, you had a fasting blood sugar of 120, right? Ask them a question about, did you miss your last dose of insulin, right? And then aggregate that quantitative and qualitative data from both the text-based intervention and the engagement piece, and then the device-based data to quite literally generate a report for the clinicians. An example of what you're seeing here of one, this is how much time you spent reviewing this data. These are the concerns that you addressed. This is the full history of messaging that we have with the patient. And this is exactly how much time you spent manually communicating with the patient. And as a result of all of that, these are the appropriate billing codes that you can actually claim, right? And we will have like an entire matrix that we'll put together around commercial and SI, around CMS codes and different things like that on a site-by-site basis. So end-to-end, from actually procuring the device to getting reimbursed for implementing it or tracking how the patient is performing and identifying who's at risk, we've helped organizations manage that. Some really quick statistics and outcomes that we've seen. So we've seen that implementing interventions like this through Memora's platform, we have published data on this, has reduced readmission rates by almost 16%, and that patients are, coming in and being activated on the platform at a rate of almost 92%, which is groundbreaking compared to portal interventions and other interventions and app interventions, which are traditionally less than 30%. And that kind of brings me to the last component that I want to mention, which is just some core outcomes that we've seen. So one of the biggest components of Memora is one, that we tie everything to some financial data point around how is this actually saving you money or generating additional revenue. And then second is, just because we are collecting this data on your patients does not necessarily mean that we are effectively displaying it to the clinicians, right? So we're able to engage patients at an extremely high rate using a lot of the practices that I mentioned and collect data from these patients at a rate of well over 20 data points per month, which is sufficient for the reimbursement metrics. And on the flip side of that, we're also reducing the number of notifications that clinicians are receiving by well over 60%, because we're accurately filtering out data that may not necessarily be actionable. And then second, identifying which data points will require some sort of intervention from the clinician. And ultimately, as a result of both time that we're saving, as well as a combination of additional reimbursement and all of those components, we're quite literally saving systems $670 on average per patient that they may have under management at that point in time. And that's data that we validated from well over 6 different sites. Which brings me to the last point around the goal at the end of the day of RPM interventions, engagement related interventions, any sort of risk assessment that you may be doing or scheduling, whatever it is to put patients through this journey where you want to kind of guide them or give them almost like this virtual assistant experience of, this is exactly what you should be expecting. And this is an overview of what the next 6 weeks of your journey look like. And this device is fundamentally going to help you make sure that you are on top of your care. It's going to identify the incentives of, why does someone not want to come back to the hospital, right? It's going to, interventions like this are obviously going to help patients understand why it's important to actually use devices like this and get high engagement from them and stuff like that, right? And this is almost an example of the journey that a lot of patients will go through at sites that have implemented Memora. Awesome. I will go ahead and stop there and leave room for questions.
Great. Thank you for that very thoughtful presentation. We do have a few questions for you. Can you say, circling back to the way that the provider engages in the integration with the EHR and existing systems, is this something that the provider is logging into within Memora, or can they pull the Memora alerts into the EHR?
Sure. That's a great question. So I think one set of messaging that has worked really well for Memora, just as an organization, is the concept of making your EMR smarter for you, right? So the goal is not necessarily just having an EHR integration does not necessarily mean that the platform is actually helping you, even if it's writing or pushing media files or writing data back into the medical record. Let me pull up, here we go. So a really quick example of what Memora looks like when integrated, and this is in Epic, but we've built integrations. So we're part of the Athena Health Marketplace. We've built integrations with eClinicalWorks, with Cerner, Greenway Health, what else? Several others, whatever other EMRs are out there. In total, around 8 different EMR systems. And what that integration always looks like is quite literally, there's usually almost like a tab that someone can click on, and it will render a version of our interface directly inside of the medical record, as you can see here. But the second step beyond that is it's not just rendering this interface where you say, hey, go to the second inbox in this one tab, we actually are pushing notifications directly from our interface directly into the medical record, right? Or from all the data that we collect. So particularly in Epic, for those who have used it, they use a notification, I guess, workflow called In Basket, where all their staff messages as well as patient messages that come in from the portal or come in from email encounters are going into this one place. And what you're seeing here is actually a screenshot of a automated in-basket notification that Memora generated based on a patient question that came in. And then we have a lot of coordination components on the platform as well around if, let's say you want to send this to another care team member, right? You can tag them in a message, quote unquote, on our platform, and it'll generate an in-basket notification and stuff like that. So it's all almost like, we kind of describe it as like an invisible layer in your EMR that reduces the number of notifications you receive and makes this data actionable.
That's great. And I know you touched on, patient engagement and activation rates. What have you learned about engaging patients and getting them to sustain their engagement? And do you have any learnings on incentives that work?
Yeah, that's a great question. So I think that engagement at its core ties into cultural competency as well. So the biggest barriers to engagement at the start are kind of meeting the patient where they are before you even determine what kind of content to send. So that means, are you messaging them through a channel that is accessible, right? Which is why Memora has strategically chosen very low touch channels like text message, email, IVR, things like that, right? Second is, are you able to communicate with them effectively? So is the language correct? Is the frequency correct? Are you, if it's an IVR solution that you're using through Memora, calling them while they're actually at work, or are you calling them after hours and different things like that, right? That's kind of the first component, right? Meeting them where they are and making sure that, through the Memora platform, similar to how CareSignal does it, we don't charge patients for any of the messages that they receive. It doesn't count against their phone plans. And then the second component after you've done that is there's an entire onboarding survey or process that patients will go through on our platform where you actually screen them for social determinants questions, right? You're asking them, is financial navigation top of mind? Is transportation top of mind? Is medication access top of mind? Are food stamps top of mind? Different things like that. Because at the end of the day, and I'll use an analogy from an interview that we did with a patient really early on when we were kind of going through the process of finding product market fit as a company. We were chatting with the patient, and the concept that the patient basically told us was that after they leave the hospital, they're not actively thinking about taking their medication. They're not proactively thinking about, hey, I need to make sure I think about my diet today because, 6 months down the line, I have to get another A1C measurement, right? In most cases, when the patient goes home, they're thinking about all right, I need to make sure I can get food for my kids today. I need to make sure that they are good to go for school tomorrow. I need to make sure that, everything the second job that I'm working, I make it there on time right after I have this visit, which I'm squeezing in between maybe two jobs that I have. So there's two fundamental concepts, and that one is you need to understand their core needs, and you need to almost tailor the messaging around that. So the purpose of doing that cultural competency process is we will intelligently actually tailor the messaging around a goal that a patient will set, or around a particular, let's say, challenge that a patient may be having. And then second, in parallel to that, we will actually work with the patient to identify how frequently should we be messaging you. If they're highly engaged and you keep messaging them, they will become unengaged very quickly, right? If they're not engaged and you keep messaging from the same channel, it's probably not going to work. You probably need to switch channels, or you need to have someone pick up the phone and call them, right? So similar to how it's like an invisible layer in the EMR, the purpose is to basically say, look, we just want to identify who actually needs an additional nudge, right? Or who needs an additional nudge, and then why they need that nudge, or what the challenges that they're facing. And then display that information to the clinician so that they can act on it.
Got it. And for some of that prepared content, did you say what languages you're offering?
Yeah, sure. So we support 109 different languages across the board. We kind of on a first pass of that content have an automated translation system that we use. We've kind of deployed after that first pass, when we're actually deploying in a specific language, we will have an external auditor actually review that content and make sure, hey, is all of this information correct? Is it, in a lot of cases colloquially written so that patients will understand it. Is it at the right reading level, different things like that, right? So there's kind of a two-step process that we go through. We've deployed the platform now across the board in, English, Spanish, Mandarin, French Creole, Haitian Creole, Swahili, Vietnamese, kind of across the spectrum.
Wow, that's great. Thank you so much, Manav. There's a couple more questions for you in the Q&A, and we really appreciate your time and presentation.
Awesome. Thank you.
Thank you. Well, that was our last company. Thank you, everybody, for all of your time and engagement, and feel free to send additional questions through the question and answer button, and we will be sure to get back to you. I know I was super impressed by all the companies and presenters today, and I hope that all of you enjoyed it, and we're so grateful to each of you for taking the time to join and engage and ask questions and really inform the critical review that needs to happen to understand which remote patient monitoring solution is best fit in your clinic environment. As a follow-up today, you will receive an email with links to the presentations and the recordings, and then also the welcome packet and any other instructions for how to get in touch with a company that you might want to connect directly with. So thank you again for your time, and we look forward to continuing the conversation online. Have a great day.